Healthcare delivery will change substantially in the coming years. This is not because of reform, but due to a set of drivers that are exerting a great push and pull on the system. What are these drivers? One is that we will see many more individuals with chronic illness. These are diseases like diabetes with complications, heart failure, cancer, chronic lung disease. They're mostly due to our adverse lifestyles. For example, a non-nutritious diet and eating much too much of it. Little exercise. We're very sedentary. Chronic stress. We all feel stressed. And 20% of us still smoke. Another driver is the aging of the population. As a society, we're growing older, and you know there's the old saying, just like with a car, old parts wear out. Another driver is the increasing demand for medical services. Perhaps this is saying the same thing another way. More aging and adverse lifestyles create more disease and the need for more and more care. Consumerism is becoming, finally, more and more of a driver of change. Patients are coming to want and expect to be treated like a valued customer. Think of it this way. The patient is no longer willing to be patient. What do patients want? They want service, quality and safety, respect. Actually, that may be the most important one of all. But also convenience and responsiveness, and closing the information gap. There is a need to level the playing field between what the doctor knows and what the patient knows about their illness. Professional shortages are definite drivers of change in the delivery system. We've seen shortages of nurses and pharmacists so far, and more there's a shortage of primary care physicians. And also, not as well recognized, is there's a shortage of general surgeons. And these shortages are more acute in rural areas and in urban poor areas. Combined with shortages are changes in professional aspirations and lifestyles. More and more we see physicians wanting and expecting more time for family. They no longer want to run their own private practices. They prefer to be employed. And among many other drivers of change is that patients will have a greater requirement toward a direct share of costs. Today we have mostly prepaid health care, meaning that our insurance covers most everything from routine exams, well baby care, all the way to a heart transplant. But there's a movement afoot to place a greater burden on the individual, whether that be through employer-sponsored insurance or government-run insurance like Medicare. Now let's switch gears now and see what these drivers of change will actually cause to happen. Once we understand some of the drivers, here's what we can expect to occur in the coming years. First, there's going to be many more patients than today. Population is growing, but most importantly, the population is aging, and our society has many adverse lifestyles. This means there'll be more and more of the diseases that come with aging, like Alzheimer's, and there'll be many more individuals with chronic illnesses. The sad thing is that many of these individuals will be moderately young, and as a result of obesity, especially since a third of us are overweight, another one-third of us are frankly obese. So there's going to be a need for more hospital beds, ICUs, operating rooms, high technology, and interventional radiology. This is different than the mantra of recent decades, which proclaimed that we had too many hospitals and too many beds. Now it's just the reverse. This is a big change. But building new hospitals or new wings of renovations costs a lot of money. So does technology, such as the electronic medical record, a new CAT scanner or an MRI scanner. To garner the needed money, hospitals will need to access the capital markets. Credit's tight, though, and it's gotten tighter in recent years. What the hospital's going to do? Well, they're going to merge with larger systems to get access to capital. So we'll see more and more hospital mergers into systems. Indeed, there will be few standalone community hospitals in the coming years. That's quite a disruptive change. What about the shortage of primary care physicians? Well, for sure there will be greater use of nurse practitioners and physician assistants, especially in primary care. No, they can't take the place of the physician, as a lot of people would assert, but they can be very effective, and they can allow the physician to do what he or she is best at doing. They can create an excellent team. Primary care docs are caught in a catch-22 today. They're in a non-sustainable business model. Reimbursements have stayed level for years, but office expenses go up each year. So in order to keep the personal income flat, they need to make it up in volume, just like anybody else would do. They do this by seeing more patients. This means they no longer visit their patients in the hospital or in the emergency room because they want that time to see patients in the office. Instead, they wait for the hospitals or the ER doctor call with reports. And they shorten the time with each patient so they can see 24 or 25 patients a day. But seeing this many patients means they can't give adequate time to preventive care, and they can't adequately coordinate the care of their patients with chronic illnesses. Two of the key things a primary care physician should be doing for optimum patient care. There are two approaches primary care physicians are taking to counter this dilemma. One's to no longer accept insurance and rather expect patients to pay a reasonable fee at each visit. Call it pay at the door. Cuts out a lot of haggling with the insurer and means that they can spend more time with the patient. But this is certainly a disruptive change, and they're just not accepting your insurance. This is kind of like going back a few decades. Another approach gaining rapid popularity is to switch to retainer-based practices. The basic concept here is to limit one's practice to about 500 patients rather than the usual 1,500 to 2,000 or more. This means more time per patient. So in return for a fixed fee of maybe $1,500 to $2,000 per year, the primary care physician agrees to be available by cell phone 24/7 and by email. He or she will see you in the office within 24 hours of a call. You get as much time as needed for whatever problem you have. And the physician will visit you in the hospital, the emergency room, the nursing home, maybe even do a house call. Results, better quality. But there's more to it. Since the doctor now has the time, you will get more preventive care attention. If you have a chronic illness, the primary care physician will take the very real time needed to coordinate your care. This means you're going to get much better care from the specialist and will avoid unnecessary tests, scans, and procedures. Better care at less expense. It's one more very disruptive and I would say transformational change which is occurring. Now, doctors like me and hospital executives like me hate to admit it, but we have a provider-oriented system. Consumerism will drive it toward being a patient-oriented service model. That's all to the good, but again, this will be very disruptive of the status quo. Another coming change is to treat patients with chronic diseases with multidisciplinary team care. Here's the way it works now. Imagine a patient with diabetes. Over time, he or she will need to see an endocrinologist, an exercise physiologist, a nutritionist, an ophthalmologist, and perhaps a nephrologist and a vascular surgeon, maybe even others. What happens all too often now is that the patient's told to see this specialist or that, and is left to make their own appointments and hope that the specialist will know what's needed for their care. The result? Excess tests, images, and procedures. Higher costs with lower quality. Much better when the primary care physician actively manages this entire team, making it a virtual team. The quality of care goes up, the costs go down. Multidisciplinary team care is much better for the patient, but it needs to be a true team, not disjointed. Cancer care is another example. Imagine a woman who has an abnormal mammogram. She's anxious, of course, and is now sent to a surgeon. He or she does a lumpectomy, and then tells the patient she needs to see a medical oncologist. She now meets the oncologist for the first time and starts all over developing a doctor-patient relationship. The oncologist does his or her part and then refers this person on to a radiation therapist. Each step is fraught with new anxieties and always unclarity as to whether the next doctor will agree with the first doctor's approach. Much better if she had met all three at once and the three had jointly offered her a plan of care. Now she can proceed knowing that each plan and each physician involved in her care is on the same page. Better care all around. But this is not the usual way cancer care is delivered today. The team-based approach makes sense, but for the doctors involved, it means a very transformational change in how they conduct business.